Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Thank you to our sponsors, Altum Dental Lab Group and RDT Dental Lab in Toronto. Hello, everyone. I'm so grateful to all of you for joining us again. Today, we have a very special podcast with my friend, Dr. Priya Jayaraman, and she is going to tell us everything that you've always wanted to ask about TMJ problems. So, Priya, tell us about yourself.
Hi, Sanj. Thank you for having me for this podcast. I am very honored to be your guest today. As you said, Priya Jayaraman. Actually, my legal name is Sripriya, but nobody calls me that. Priya is good. I've been a dentist in North America. I think this is my 15th year of practice. And I've been doing TMJ disorders and chronic orofacial pain conditions, dental sleep medicine. I got started in 2018. So 2018 to 2020, I did residency in University of Kentucky. And then, we moved here to Greater Toronto area, which is home now. And I've been seeing patients for that for, it's about 5 years already. Time's flown.
Wow. So was that a specialty in the US?
Yeah.
TMJ and oral facial pain? Wow.
Yeah.
I'm honored to have an expert like you on the podcast because I have so many questions to ask.
Bring it on. I'm really honored to be here, I have to tell you.
Oh, thank you. So the first question is, when we're doing a TMJ assessment and we're hearing that click, but the patient's like, hey, it doesn't bother me. Should we do anything about that?
Leave it the hell alone.
But how about if they say, oh, my jaws hurt in the morning. I think I'm like clenching or grinding at night. Now what do we do?
That's an excellent question. The question we have to ask ourselves before we do any treatment, whether it is dentistry or medicine, TMJ disorders, doesn't matter. We always have to ask ourselves the question, what's causing the pain?
Mm-hmm.
So if you're strictly speaking TMJ disorders, is it muscular? Is it inside the joint capsule itself would be the biggest question. Depending on what we get as the answer, which is what's our diagnosis, always comes back to that, what's our diagnosis? The treatment gets driven towards trying to solve the etiology, basically.
Okay. So if they do say, hey, I'm clenching and grinding at night, what's the diagnosis? What's the treatment?
That's where you kind of get into a little bit more involved into the exam. Is it Is it just pain when they wake up in the morning? Is it pain throughout the day? Is there associated headache? Depending on what they say to that, night guard probably is a good option at that point. Botox might be a really good option for some patients. Then depending on, again, the case, medications, anti-inflammatory medications is have at it. Motrin, Advil, Tylenol, Aleve, but take your pick. Muscle relaxer. Again, if you're comfortable maintaining a patient on muscle relaxer for a long period of time, please have at it.
And now you mentioned night guard. How should that night guard be designed?
Another excellent question. So again, everything depends on the patient because there are so many different kinds of night guards that you can fabricate. You can tell the lab basically to make a night guard for you, and a good lab technician will make what you ask. So my go-to night guard is an upper full arch.
Okay. Why upper, not lower?
Personally, I find it's easier to equilibrate an upper just because, as we know, the lower jaw is essentially slightly smaller than the upper jaw, right? So slightly. So when we have something on the upper jaw, something covering all of the upper teeth, it's easier to get the acrylic to touch the lower teeth. It's just easier to equilibrate it.
Okay.
When you have it on the lower teeth, sometimes I have seen when patients clench, and the upper teeth kind of flare out more when they start impacting.
Okay.
The upper teeth flare out more. So,
okay, upper full arch. What material?
hard acrylic, hard soft, pro forma really doesn't matter.
Okay.
Material doesn't really matter.
And how about those thermoplastic ones where you warm them up and then put them in?
It's fine.
Okay, good.
It's fine.
And then you mentioned Botox. Recently, I had a patient just a couple of days ago. She's 20 years old. She said that her condition got so bad that she couldn't open her mouth to eat. She was constantly in pain. So she went to her medical doctor, paid hundreds of dollars for Botox.
Okay.
And she said she feels so much better.
Thank you.
But I said, well, Botox is temporary. Like, are you going to spend several $100s like every few months for Botox? So tell us about that. Tell us about Botox for TMD.
Yeah, that's another really important question. The effect of Botox is certainly temporary. In theory, the effect can last anywhere from 8 weeks to about 14 weeks is about what we say in theory. But in practicality, I have seen patients, they call back in about 8 weeks, sometimes saying, hey, my pain is back. How soon can I come back? And then there are patients, I don't hear back from them for like 9 months. So again, everything depends on the patient. And I hate to say this, a lot also depends on the patient's budget. Because Botox as a treatment, it is not covered by OHIP, especially if it is for TMJ disorders. It's not covered by OHIP. And many private insurance companies, again, it's a bit of a fight with them. As a doctor, I have to write letters. In fact, one insurance company, I can't remember the name of which, they asked me, they straight up asked, can you show me human control studies that prove effectiveness of Botox for TMJ disorders? I'm like, oh, why one? I give you five. And they ask you things like that, and there is a big list, like 5-6 page form you have to fill out for patient. And after all that, they cover only a partial portion of the treatment. So finances are definitely a limiting factor. But as far as how many times can you reasonably do for a patient, again, I would say for young people, really doesn't really matter the age of the patient. No more than 3 times in a year.
Okay.
Yeah, 3 times would be once every 4 months. It's more than enough.
Okay. But so what I told this young person is that's fantastic. Botox is working for you. If you can afford it, keep doing it. But how about we get down to, why you're clenching your teeth, like you're stressed. Like let's talk about how to decrease the stress in your life, stress management, because she's a university student. Be conscious of where your teeth are. They should only touch when you're eating. So puff out your cheeks when you're clenching. Like I was trying to do that, like go even upstream because I don't want her to waste her, limited budget on Botox. So what are some ways that we can, non-pharmaceutical ways, cheap ways that we can get our patients to, decrease the clenching and grinding and help them with their TMD?
Oh, actually, you hit upon one really good aspect of it, which is stress management. While, while I would hesitate a little bit to say stress is directly an effect of a cause of TMJ disorders, not really, but it does fuel the fire. So, as you rightly said, cognitive behavior therapy is maybe one of the best things. And when it comes to a lot of musculoskeletal type of conditions, and it doesn't matter whether it is TMJ musculoskeletal pain or even shoulder pain, back pain, leg pain, doing exercises, physiotherapy, self-care, cognitive behavior therapy, they're probably some of the best things that our patients can do that will help them manage their pain that are not pharmaceutical.
Good. So is there a helpful resource where we can find out about TMJ exercises?
Typically, what I tell patients is it's just one of those double-edged sword type of things. Like if we are having back pain or leg pain, for example, we can go foam roll it out or we can stretch it out and then feel a little better. But to me, and then this is completely my personal opinion, I don't think I have read any studies about it. When we're doing jaw exercises for relief of TMJ pain, to me, somehow it is counterintuitive because when we exercise a muscle, we kind of take it to the end range of motion, basically. So if let's say I'm having finger pain, I just
Bend
really
it back.
stretch it to the end range of motion. But in TMJ disorders, what happens is if you take things to the end range, that can itself be a trigger for the pain.
Oh,
So you have to stay within the range where it doesn't trigger pain. So if opening your mouth this big is
yes.
what triggers your pain, you only open this much.
Okay.
Or sometimes what you can do is you can put warm compress on your face, kind of warm up the muscles a little, and then you can do some exercises, some opening, closing exercises, side to side, uh, opening against resistance type of exercises. But my
Okay.
sincere advice is when it comes to exercises for TMJ disorders, better to do it under the guidance of a skilled physiotherapist or a chiropractor.
Oh, okay.
Yeah, somebody who knows what they're talking about, someone who can give you laser acupuncture, things of that nature. That way, slowly you can increase your range of motion of your mouth opening and your lateral excursions, as opposed to just looking at a video and then going at it, and you kind of hurt yourself more.
Okay. Yeah, good advice. I was going to ask you about that. Physiotherapy, chiropractors. You mentioned that those are great places to go. How about massage therapy?
Massage therapy also can be really helpful, manual therapy, that can be really helpful.
Okay.
But I would really hesitate to say there is one magic bullet that is sort of a cure all, a panacea for TMJ disorders. Typically, and it's hard to say what kind of patient responds to what kind of treatment. There is no phenotyping a patient like that, and there are no biomarkers for patients like that.
Okay.
So it's always interdisciplinary care, it's always multimodality uh, approach to patient care. The other thing also with a lot of young patients who suffer from TMJ disorders, a lot of them also have comorbid conditions like anxiety, depression,
Hmm.
PTSD. They take medications for that. There is IBS more often than not, interstitial cystitis if it's a female presenting patient. So we kind of have to take all of that into consideration and see that they get help from every different specialty. So there is no one magic bullet,
Okay.
unfortunately. So it's multidisciplinary.
All
That's
right. Thank you. When you mentioned warm compresses, how long should they keep it at the joint or the
10
muscle?
minutes on 10 minutes. 10 minutes on 10
10
minutes.
minutes on, 10 minutes off. And how many times a day?
Two, three times a day.
Okay. And then how about ice therapy?
Ice is also fine. Again, patients always ask me that, is it better to do ice or is it better to do heat?
Yes.
Um, some people say if it is muscular, do heat. If it is joint, do ice. But my take on it is, a little, I guess, almost controversial. But if it is cold like today, putting ice on your face is extra cold. I mean, why do you want to do that? But if you have warm compress on your face, you're huddled in a blanket,
Yes.
you're playing with your pet, you're watching Netflix with a little hot chocolate in your hand. It feels
Yes.
good. It enhances
Yeah, it
your sense of
does.
well-being. And again, Corona area, we get a lot of humidity. Personally, I think it's too hot here.
Yes.
So, you have a little ice on your face, a nice cold drink, there is AC breezing, you have Netflix playing in the background. Again, it feels good. It enhances your
Yes.
sense of well-being. So I said, if it's hot, do ice. If it's cold, do warm. It's
I like
fine.
how practical that is. Now, when does the issue get so bad that we should refer the patient for TMJ surgery?
Oh yeah, you really walked into this really big pit of controversy, I would say. So
Okay.
first, let's sort of separate TMJ disorders into two big buckets.
Okay.
One bucket is outside the joint itself. That would be musculoskeletal disorders. It's completely muscle pain. There is no surgery for that, unfortunately. The other thing is actually intracapsular pain, which is actual joint pain. And when we have joint pain, surgery is just one of those. And again, by surgery, I'm talking open joint surgery. That is just one of those last ditch efforts. So before we actually take patient to open joint surgery, there are many things that we have to do and patient has to fail. So conservative therapy, medications, physiotherapy, night guard, trigger point injections, nerve blocks. We have to have exhausted all of that. Then the next step to that would be arthrocentesis. Okay, patient is not getting any relief. Second round arthrocentesis, still not working. Then we go to arthroscopy. Next round arthroscopy. Once we have exhausted all of those modalities, if patient is still not getting any relief, and we also should see joint pathology. Typically, it's joint arthritis. So if we have all of those conditions, then a patient would qualify for, oh, maybe we should consider some open joint surgery. And what they do is the first surgery, they remove the joint, they remove the disc itself, and they do fat grafting in the disc. And then that gives patient some time. Okay.
Can you
After a
explain
few
that
days,
again? They remove the disc and they do
fat grafting. Fat.
really
Yeah, they graft fat.
fat grafting.
Yeah.
From what part of the body?
Don't quote me on this. I guess I'm speaking, but again, I'm not 100% sure. I think they take it from the abdomen, although I'm not 100% sure. Yeah.
Okay. So it's from another part of their body. They graft. Wow.
Yeah. And then
Okay.
once that fails, we are talking total joint replacement.
Yes.
Yeah, but that's
So once they've exhausted everything, so it's rare that someone would need total joint replacement.
yeah, absolutely. And again,
Okay.
because we live in Canada and this is all OHIP covered service, by the way.
Oh, good.
All OHIP covered service. So arthrocentesis, it can be done in private practice where patients' insurance might cover it or patients pay out of pocket. But arthroscopy is done in a hospital setting under general anesthesia. It's an OHIP covered service. And from then onwards, everything is OHIP covered. So because of that, the surgeons are very, very careful about picking the patients, selecting the right candidates, and making sure that all conservative options are 100% exhausted before they actually put a knife in the joint.
I like that. Now, can you explain arthrocentesis and arthrography? Arthroscopy. Arthroscopy. Yes.
Sure. So arthrocentesis is considered a closed joint procedure, basically. It's a very, very conservative procedure. Again, there is a spectrum, I guess. But arthrocentesis is very conservative. A patient will be sedated, so they will be put to sleep, and they take two little needles and they place it over the affected joint. And then after that, they pump into the joint a lot of saline and lidocaine and hyaluronic acid and steroid. It sort of makes a circuit. One needle is here, right about here, and another needle is 10 centimeters in front of that. It makes a circuit. So when they pump all of these fluids into the joint, it removes the inflammatory exudate along with it. That's what is supposed to give patient pain relief. And then they remove the needle, they put a band-aid over it. That's all is
That
arthrocentesis.
sounds so simple. And how long does that last?
It depends on the patient. There are some patients, once arthrocentesis is done, they're like, I feel really good. Peace out.
Awesome.
Yeah, there are some other patients to whom sometimes they might need a second round of arthrocentesis. And then if that doesn't help, we are escalating to scopy.
Okay. Good. So when dentists refer their patients to you, what is the most common reason why they're referring to you?
Yeah, actually, I would say about 60-70%, no, 60-65% of my referrals are for TMJ disorders.
Okay. And so describe the TMJ disorders that they have.
Typically it is musculoskeletal.
Oh, okay.
Musculoskeletal, yeah.
So it's rare. So musculoskeletal issues are more like reasons are more common than joint reasons. Okay.
Absolutely, absolutely. And then some more, if not musculoskeletal, then there will be actual intracapsular pathology. I get a fair amount of those patients. Other than that, I get fair amount of neuropathic pain patients.
Oh.
So trigeminal neuralgia, all kinds of trigeminal neuropathies. I see a fair amount of those patients. Burning mouth disorder, that's again,
Wow.
I would say about 5-6% of my practice is burning mouth disorder. Then I also see patients for mandibular advancement device for sleep apnea.
Oh,
There are
cool.
some other, I mean, I'm saying this as a joke, but I get some patients whose condition is so complicated. My mind is just going, what the heck, yo? What's going on here? Because they don't fulfill the diagnostic criteria for anything. So is it TMJ disorder? Is it musculoskeletal? Is it neuropathic pain? Is it headache disorder? Are we staring into a syndrome? There is just, it's like a buffet. a little bit here, a little bit here, a little bit here. Then it is my job to say, okay, this is the cluster of symptoms. This is what I see in the exam. How can I connect the dots in a way that it makes sense to me? And the way I tell patients is, I'm not making you fit into a box. I'm not pushing you into a box. I'm laying out everything you said, and I'm laying out everything that I have seen in my exam, and I'm connecting the dots in such a way that makes sense to me. With my education and training and specialty and everything, I am trying to connect the dots in a way it makes sense to me. Maybe if somebody else heard it, they might connect the dots in a completely different way. Perfectly valid. But to me, what's making sense? And then we do trial therapies. Okay, this looks a little bit like a migraine disorder, but then there is something called orofacial migraine.
Wow.
Neurovascular orofacial pain. So they check off all the boxes for actual migraine headache, but there is no headache. So
Interesting.
yeah, oh yeah, yeah. I get a fair amount of those patients too. So a little bit here, a little bit there. As I said, it's a buffet. So part of my job is to lay it all out and then connect the dots in such a way that makes sense.
You're like a detective.
Yeah, that's exactly how I feel. Yes, Miss Marple. Agatha Christie for the win.
Bill, you said that most of the referrals are for musculoskeletal TMD. So can't a general dentist just handle that on their own?
Absolutely. Absolutely.
So, for example, you said like heat therapy, ice therapy, muscle relaxants, anti-inflammatories,
Yeah.
referring them to, massage, acupuncture, physio, chiro, a night guard. Is there anything else I missed that we can do?
Botox and trigger point injection.
Botox and trigger. So what can general dentists do trigger point injections?
Absolutely. If you know what you're doing, have a take.
So what are you injecting with?
I typically inject carbocaine.
Okay.
Yeah, and what's very important is when you're injecting into the muscle, there should be no epi. No epi.
Okay.
Headache,
No epinephrine. Plain
no
anesthetic.
epi, no epi. Yeah, no epi.
Okay.
So you can inject plain lidocaine, it's fine. But I personally prefer carbocaine. But again, if carbocaine is not available, plain 2% lidocaine is good.
So with that, isn't it temporary?
Again, that's a good question. Depends on the patient. So the first time you do it, again, it can be diagnostic and therapeutic. So you inject into the trigger point, and then the patient says, "Yeah, it's good. This is the pain I was having, and I feel a lot better." And then we see, okay, how long is the pain relief lasting? If the pain relief lasts 2 to 3 days, sometimes the first time injection it doesn't last very long. After about a month, couple of months, you can always re-inject with the hope of giving the patient longer lasting relief. So I think about 9 months, most of the patients they don't really come back. I'm
Oh,
not saying
good.
I cured the patient. Please no, I'm not saying I cured the patient. Typically they don't come back.
Nice. Now, how about doing orthodontic treatment? Does that cause TMD? Does that alleviate TMD? What are your thoughts on that?
Does it cause TMD? No.
Okay,
Does
good.
it alleviate TMD? That can be a little controversial because we have not talked about the cause of TMD, and then I won't go far enough to say all TMDs are caused by occlusal disharmonies because that would be absolutely wrong thing to say.
Okay.
But there are some patients. Again, the case selection, the diagnostic decision tree, it's pretty long and complicated. But there are some patients to whom you absolutely have to dial their occlusion. So that's when doing orthodontics, full mouth rehabilitation, even orthognathic surgery sometimes would be the way to go.
Okay. And how about, doing occlusal adjustments?
Same thing.
Do you?
Yeah, it's a decision tree. So occlusal
Oh,
adjustment,
okay.
occlusal equilibration, that is probably of the things that we can do. I mean, it's still invasive because we are breaking down teeth, we are cutting teeth. It is still invasive. That would probably be the most conservative of the invasive stuff. But when we
Okay.
start getting into ortho, crowning 28 crowns for all of the teeth,
Yes.
or orthognathic surgery would be the absolute end of the spectrum.
Mm. So occlusal equilibration is a possibility of is one of the options we can do for patients with TMD.
In selected patients, not everybody,
Okay.
that's for sure. But in select, as I said, the decision tree is a little complicated. But
Yeah, I find it so hard to determine that. So that's when I'm going to refer those patients to you because I don't want to start cutting down teeth,
oh yeah,
if I
absolutely. And
don't have
you shouldn't
to.
have to for all of the patients. And
Yes.
even then, even to me, the way my office is set up, I don't really have any drills. I don't have hand pieces. So
Wow.
if the patients need occlusal equilibration, if I think that's the way to go, I usually
Yeah.
refer patients back to their dentist.
And you just tell the dentist where to equilibrate.
And not even, I will just say occlusal equilibration might be good.
Wow. That's great.
But most of the patients at that time, they go for ortho actually. I
That
mean,
is
there
the
are
best.
some dentists who do occlusal equilibration, to be fair, some dentists do that.
Okay.
But a lot of the people that get referred to ortho, and I can kind of see the merit of it because ortho, yes, you are moving teeth, yes, it is irreversible in that sense, but you're not drilling the teeth, which is nice.
Yeah, I like that too. More conservative. Now, how about if we encounter a patient whose jaw locks open? How do we get it back?
Oh, okay, very good question. So, again, we have to ask the question, is the jaw lock happening because the patient is trying to open their mouth big? So, if the patient is they're trying to eat a quintuple burger, for example,
Yes.
they're opening their mouth really big and it locks open, then treatment for that, again, some patients have pain, some patients don't have any pain. If they have pain, again, you go with the pain control modalities. If they don't have any pain, actually behavior therapy is considered one of the best. Don't eat a quintuple burger. Some patients get good benefit with physiotherapy, that can be quite helpful. But this is for patients to whom they're actually opening their mouth and it locks. There are some patients to whom jaw locking, spontaneous mouth opening, it is spontaneous. They're sitting and chilling, and then boom, mouth just flies open.
Wow.
That is a neurological condition. It's called dystonia, oromandibular dystonia. They need Botox.
Really? So if I'm working on a patient and their jaw locks open and they're like, I can't close, what should I do? Should I push down and back?
Yeah, you don't right away push back, push down, and then take
Yeah.
it.
Okay. Good. And how about people who have hypermobile joints? Are they going to be locking open more often than others?
Hard to say. Some people
Okay.
might, some people might not. And then people who have hypermobile joints, um, uh, some might even have Ehlers-Danlos syndrome, for example,
What is that? Oh,
EDS.
Ehlers-Danlos
Yeah,
syndrome.
Ehlers-Danlos syndrome.
Yes.
Yeah.
Okay.
So they are
Where
generally,
all their joints are
yeah, they're
they're
extremely
very
bendy people.
flexible, their skin is even flexible. Yeah.
Yeah, they're very bendy people, and they also have lot of pain. So in GTA, there is an EDS clinic. I'm not sure, somewhere downtown. I don't know if it is Toronto Western or Toronto Rehab, I'm not sure. Yeah, there is an EDS clinic. So patients, they go there for part of their chronic pain management.
Oh, great. Now we have to have you back to talk about oral facial pain and burning mouth syndrome. But this has been fantastic. You have answered my questions on TMD. Now, do you have any useful resources that you think that the listeners should, look into to find out more information about TMD management?
If the listeners are dentists, I'm thinking they
Yes,
are.
they are. They
Okay.
are.
So there are some good textbooks actually that would be good to look into and read. And the textbook that I have been referring since my residency was the book written by Dr. Okeson,
And
Temporomandibular.
what's temporomandibular joint disorders?
Yeah, Okeson, Okeson.
Thank
Um,
you.
he is the god of, well, one of the gods of orofacial pain, TMJ disorders anyway. So his textbook, it's very, very informative. For dentists, I think that would be an excellent resource.
Great. We do have some pre-dental students and dental students who are listening as well. So shout out to, Oliver the Future Dentist, they could read that textbook as well. How about for patients? Is there any useful resources for them?
It's a good question. I usually hand them out material when they come to clinic, but I'm not sure. Yes, American Academy of Orofacial Pain probably has some patient care resources, I'm gonna
Oh,
say.
great.
I think,
Excellent.
although don't hold me to it.
Okay. And if the listeners would like to contact you or refer to you, how can they reach you?
Oh, they can reach me through our practice website, Crescent Oral Surgery. Crescent Oral Surgery. They can reach me through the website. Email and phone number are there. If they want to reach me directly because they had a question about a patient, I'm available by email. It is my first initial, Priya P, and then my entire last name, Jayaraman, Jayaraman at crescentoralsurgery.com. Crescent like the crescent moon.
Great. And where is that office located?
We have 3 offices. One is in Scarborough, one is in Richmond Hill, and another is in Aurora.
Great. So, Greater Toronto area, you can reach out to Dr. Priya Jayaraman. She is an oral facial pain and TMJ pain specialist. It has been fantastic to have you on the podcast. We are looking forward to a follow-up episode where we can learn more from you. So, thank you, Priya.
Thank you, Sanj, for having me. This has been a pleasure and an honor.
Thank you to all the listeners for listening. Until next time, bye.
Bye.
This podcast is sponsored by RDT Dental Laboratory, your full-service dental lab in Toronto. RDT Dental Lab will help you grow your practice through education, predictable restorations, and high attention to your clinical needs and patient experience. Check them out at rdtdentallab.com. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.